One thing that happened, I'll never forget this. I had a guy come in to do a coverage for me on a weekend, right?
Yeah.
Over that weekend, he killed 2 of my patients. Straight up, yeah. He came in, mismanaged them. I came back and they were dead, right? One of the guys, one of the guys, I came in to get sign out from him.
Yeah.
On Sunday night, and he said, "Oh yeah, this gentleman's been here. He's real sleepy. He's real sleepy. Yeah, we haven't been able to wake him up. And I'm like, oh, okay, he's real sleepy. Like, how long has he been asleep? Oh, since Friday. He really hasn't. I said, I'm sorry. What?
What?
The guy's been asleep since Friday. Like, what have you done? Oh no, he's just real sleepy. We just say I think he has a urinary tract infection. I think that's what's going on.
But he was an admitted patient to the
hospital.
He was an
admitted patient, yeah. And I'm like, you think he has a urinary tract infection, but he's been unresponsive since Friday. It's now Sunday night.
Welcome back to Dear Healthcare, It's You. Welcome back to the podcast. Elisha Yaghmai here with us from Free State Healthcare in Wichita, Kansas. My name is Joe O'Hanlon. Thanks for being here, Elisha. Where we've been going is talking about your medical journey, and last we left off with you about to enter the real world as a real world doctor, and you mentioned that you ended up starting out your doctorship, or what is the proper phrasing of that?
Typically, you become a quote unquote attending physician.
Attending physician, and is that what you remain forever?
Yeah, okay. That's right. There's different terms in different countries, but in the U.S., basically, you're a medical student and you're a resident.
Yeah.
You could become a fellow after that, which is another level of training if you do additional training beyond your residency. And then once you're done with whatever you're going to do, you become an attending physician, which means you're basically at the end of at least at the formal education part of your journey.
Okay.
Yeah.
So as an attending physician, you're starting off in Parsons, Kansas, if I remember correctly.
Yeah, that's right.
And where is that?
It's in rural Kansas. It's in southeast Kansas.
Southeast Kansas. Yeah. How small of a town are we talking?
I can't remember the population. Maybe
is there
10,000, something like that. There is a Walmart.
Okay. There
is a Walmart, yes.
No Target.
There's no Target, no.
No Starbucks.
Nope. There was a Walmart and there was like a main strip downtown at the time. And there might have been a little bit more, but it wasn't a huge town by any means.
Did it have high schools, like infrastructure and stuff like that?
They had some schools, but it was... I don't recall it because I more or less lived at the hospital while I was there, but it was pretty, it was a relatively small town.
Yeah.
They had some amenities, but not very many. There were a couple of fast food restaurants, right? There were some stores and shops. There was a Walmart that was kind of the dominant retailer for almost everything.
Yeah.
And then there was a hospital.
Okay.
Yeah.
And I want to ask, because we haven't really talked about your personal life very much in the midst of this journey, but obviously that's a factor. Everybody has their stuff that is going on outside of school, and now it's outside of your work. But this is a point in a lot of doctors' journeys is having to move somewhere random.
Right.
And so can you talk a little bit about that of like, were you married at the time?
I was, yeah.
With kids or?
One child. Yeah.
One child. What was that combo like? Was that expected? Like, I know we'll have to go move somewhere.
Yeah.
At some point.
So what had happened actually was my wife is also a physician.
Oh, okay.
And so we had gotten married midway through the 4th year of medical school.
Okay. Were you in the same year?
We were in the same year.
Okay.
Yeah. Yep. And we had our first child shortly before. About a little. At that point, he was. I'm trying to think about what year this was. So he was approaching 2 years old at that point.
Okay.
And so, my wife had finished residency before I did, so she had been out working while I finished my residency.
In Wichita?
In Wichita, that's correct, yeah. And then while I was finishing, she was applying to fellowship programs, had been accepted to a fellowship program up in the Northwest.
Okay.
And so we knew that we were ultimately going to be going there, but there was this gap of time between when I finished, because I finished a little bit off cycle because I changed residencies, right? So there was a little bit of credit that was passed around.
Took a little longer.
I didn't do the full 5 years. I did 4 years and several months, right?
Right.
So I finished a little early, so there was this gap. And so, in choosing what to do at that point, I opted to go out to work in rural Kansas.
Okay.
To gain experience, and then also just to have the experience of working rural.
And remind me, you'd been with a family practice before, but that was all still, none of that was in rural areas, right?
That was residency training. Right?
Yeah,
So I came and did 1 year of family medicine before switching to internal medicine pediatrics, which is a different residency. It's a 4-year, so family medicine is a 3-year program.
Right.
Internal medicine, or med peds as we colloquially call it, is a 4-year program.
Okay.
Right. So I did the 1 year of family med, then I did almost another full 4 years of med peds,
right,
and then finished up my program there. So at that point, I was doing internal medicine and pediatrics.
But was this your first time in a rural setting for
more or less? I mean, I'd gone out to do
so
you can do something called moonlighting in residency, which is where you have your residency job, right? That's your main thing, and then you can go out to other places to work on the side.
Okay.
I actually did quite a bit of moonlighting. So you can get your medical license after you pass certain tests, and then you can go out and work in a moonlighting capacity while you're still a trainee. And people do that for 2 reasons, really. One is to gain experience, and the other is because usually they're broke.
Right, because it's actually being paid rather than
it's paid work, right? And so you get you get some extra money, and then you also gain professional experience. So I worked all over. I went out into some rural communities. I worked in urgent care. I worked in the neonatal ICU. I worked anywhere I could work, really, to try to gain professional experience, because there were things that you encountered going out into the real world of medicine that you really didn't see in a training environment. At least I could speak only for my own training environment. We didn't see it in there, but we would see it when we went out into these other places.
Yeah. And so you were going kind of nonstop throughout all of medical school, which sounds like is always the case pretty much for people.
Largely true. Yeah, I mean, this was through residency, but yeah, I mean, so some people, some residents only do residency. Like that's all they do. For some of them are restricted by, immigration rules and things like that. Okay. Others just choose not to do any moonlighting.
Right.
But then others of us chose to do both. So we do our residency work and then we do moonlighting on top of it.
Right. So then when you've become an attending physician, you're in Parsons. What was that like? You were at a hospital as I
was a hospitalist.
A hospitalist? Okay, right. So does that mean that you work in just like the pediatrics department or all over
basically,
floating?
So that hospital at that time had a hospital floor and then an ICU.
Okay.
Right, and so my job was to be responsible for the hospital, anybody on the hospital floor, which was nearly always an adult. They had occasional pediatric patients, which I think they'd had a local pediatrician would come in and do those admits, if I recall correctly. But basically, it was adult patients that were coming in, and then on certain weekends, I'd also do the ICU. Okay. They had another doctor at that time that was covering the ICU. I would fill in periodically when she was off. Okay. And cover that as well.
Gotcha. Yeah. And so, what are those shifts like? Is it like a few days a week, 5 days a week?
No, I was on basically outside of weekends when I was off. I was there every single day. Yeah.
For 12-hour shifts?
Yeah, you'd be there. Yep, 7 to 7 was typical. Yeah, and then you'd get called at night for admission sometimes and things like that as well.
Gotcha. Yeah. And that's kind of just about the job. That's not about you being new, right? That's
no. That was the job. I mean, it's basically they needed staffing, right? Yeah. So I was filling in, covering days and nights and just doing the whole thing as one shift. Gotcha.
Yeah. And you mentioned before really, really liking your time. I forget right at the moment if it was during your residency or during your your 3rd year, but at the doctor's office where he just left for 2 weeks.
4th year of medical school.
Yeah. Mm-hmm. Yeah. And so, I mean, was that a similar joy of being kind of on your own, being in charge of your own profession in that way? I mean, you're in a hospital, so it's a little different.
It was a strange, my experience, I think, I would say that my experience in medical training was sort of I don't know if it was unusual or not, right? I can't compare to everybody that did it. I can only speak for myself. Going through the early part of medical training, I did not appreciate how invasive medicine was. It's the best way I can describe it. Medicine as a discipline is very invasive in that there's a massive amount of information to know. It is always increasing. There's always new research coming out, right? And to gain skill at it, there is a point at which you essentially have to take most of the rest of your life and kind of put it on a shelf. And say, I'm not going to really pay any attention to this for a while. All my other previous interests, hobbies, all the other things I used to read, right? I'm going to set this on the shelf, and I'm just going to have to focus on this one thing.
Right.
For people that like sports, I would put up the analogy of, it's like the Kobe Bryant, I'm going to do 2,000 shots a day, every single day, right? I'm just going to get in the gym at 4 a.m., and I'm going to stay there for however long it takes, and I'm going to put up my 2,000 shots, and I'm going to do my drills, and I'm just going to do this every single day, indefinitely, right? Because that is what's required for me to be the best at this that I can be, right?
It's not like the 10,000 hours. Malcolm
it's not. It's probably
like
way more than that. It's way more than that. Yeah, it's way more than 10,000. Yeah, and you have to do this at some juncture, right, in your training, whether you do it early or later or the whole time. It probably varies from person to person, but you have to do this. residency was the time in my progression that this really happened, right? That I was like, okay, I'm not going to try to do all this other stuff. I had a fairly diverse series of interests all the way, high school, college, even through medical school. There was that point where I was like, this is the thing, and I'm just going to need to do this.
Yeah.
So all I did basically was work, read about medical topics, read new papers, work some more, try to learn procedures, right? And that was basically the thing around the clock every single day for years on end.
With your wife being a physician also, where you were able to kind of like go back and forth and talk about things and have that be part of your home life kind of cadence?
I think it also helped because I think it's difficult for a non-physician. I think other fields probably have a similar requirement, right?
Yeah.
But for a non-physician to understand that, you know, you're going to have to put in the 14, 15 hours at the hospital.
Right.
And then you're going to have to spend more time reading.
Right.
You know, and you're not going to be around for everything.
Yeah.
You know what I mean?
Tolerance for one another because you're needing tolerance for each other, like for yourself.
Yeah.
Like,
you have to understand that, you know, just the basic, right? Because a lot of physicians that get married to non-physicians, well, in general, physicians get divorced, right? Fairly, I don't know.
Oh, do they?
I don't know statistics. Yeah. It's not uncommon. I had classmates that got divorced during medical school.
Yeah.
You know,
such high demand.
They're gone,
like,
right? They're gone. These people were married to non-physicians, right? And again, I'm not commenting on their relation. There were probably all kinds of reasons, right? I wasn't privy to it, but it's a lot of stress.
Yeah.
This person is gone. You know, the training is their main priority a lot of the time, right? And some people understand that, and some people don't. Like they're just not content to be like, hey, you know, you're just going to kind of not be here for the next 3, 4, 5 years, right? You know, and I'll just sort of wait around for you to come back.
Down the hatch.
You know, it's like, you know, I'll be here with the kid, or you know what I mean?
Right,
like I'm just going to be here, and you just sort of show up when you show up.
Yeah.
Not everyone's good with that. So having at least some level of professional understanding of getting right what this is and what it requires.
Yeah, I imagine that was a huge support. Honestly, probably more than is easy to see from the outside of having not gone through that. But having someone who understands that level of like, and then be able to be on the same page if that's my one hobby right now also is medicine. Like, you both only have one hobby. It's medicine. Well, so then what was the transition like moving into this role in the hospital in Parsons? I mean, was it totally different? Did it feel familiar? Did it feel good? What was it like?
No, it was. I mean, so that, I think, I would describe it as that was sort of the payoff, right?
Yeah.
Because the payoff was I had done all of this work, right? Trying to learn all the, you know, I would come in really early. I would come in early in residency to get the hardest patients. Like I would do this intentionally, right? I would try to get up as early as possible so I could come in so I could get first pick of the patients. And my goal was to pick, I wanted to pick, because whoever got there first got the first sign out, right? So I would try to get there as early as I could to try to take the hardest patients. I wanted the most complicated and difficult patients there were, right? So on my service, right? So this is the thing, and I, you know, and I'm not an early bird type person.
If you're burning the candle at both ends, that's hard to be like, I'll choose the hardest assignment. But like, I mean, that's pretty wise for a young self at the time.
The problem you have, right, is that the more you do it, you realize that you have to do this, right? Because medicine is. The analogy I've often used is it's like water washing over rocks, right? You have to encounter it. Let's pick a diagnosis. You have to encounter it. Then you have to encounter it again. Then you have to encounter it again and again and again and again, right? And you have to keep doing this because the whole time what you're doing is you're burning patterns into your memory, right? This is what you're doing. And so you need to see, first you need to just figure out the drop dead obvious common diagnosis, right? Like what is, okay, you know, it's just blatantly obvious what this is. First, you have to get that, right? And you're trying to do that through the early parts of your training. But then you have to get, well, what happens when that common diagnosis comes in, but it doesn't look like it normally looks? Right. It looks different from normal, right?
Can you give an example of that? Like,
so I'm trying to, you know,
one.
Yeah, I mean, it's what's an easy, well, okay, so a simple one would be, you know, somebody comes in with heart failure, but it looks like pneumonia.
Oh, interesting.
Yeah. Okay. So the initial person seeing them says, I'm admitting this pneumonia to you, right? Okay. And then you go in and say, yeah, this doesn't, you know, it's not exactly pneumonia, right? Maybe, you know, they don't have any history of heart problems, but I just don't think this is pneumonia, right? I think this is something else. right? And then that has to trigger,
from
right?
indications that you're seeing in their file or in their symptoms.
You're looking at their vital
like
signs. You get their history from them, right? You look at their lab studies, right? And you just say, the easiest way to describe it is, I'd put it this way: the kind of mental process that goes on is you get fed pieces of information.
Right.
So let's just say, we'll do it the typical way. The ER calls you up. This is from the hospital perspective. The ER calls you up and says, I've got so-and-so down here. They're this age. They have these problems. And I think the diagnosis is this. They need to be in the hospital. Right?
Yeah.
So you go through first, do they really need to be in the hospital or not? That's a different discussion, right? But let's assume they do. Then you're taking in that information. You're taking in their vitals, their history, their lab data, their imaging studies, right? Typically that. And then you're mentally sort of, how can I put it? There are different diagnoses that are suggested by the story.
Yeah.
And then mentally you're sort of ranking them, right? And sometimes you end up with things that are equally ranked, right? Then you need to do more testing, right? But you're kind of moving up and down on a probability chart. It's not a formal probability chart, but it is an informal probability chart. So you're saying, what's more likely? What's next most likely? What's next most likely, right? And in medicine, we call this a differential diagnosis, right? What's the list of things that could cause this symptom? But many of them are rare. Or you look at them, you're like, yeah, that's definitely not it, right? Toss that one, toss that one.
You're like starting with the whole WebMD list.
Yeah,
Like,
that's right.
I have a headache, so you're dying.
That's right. Yeah, exactly. Yes. So if you have a headache, it could be a brain tumor, right? Or there's a long list of other things. So you do that, and so you're working through that process of stratifying things and sort of ruling things in or out, right? But to, so for example, they call you and say it's pneumonia, right? And then you go say, well, what's the story here, right? Well, what's your story, patient, right? And they tell you a story and you listen to it, and you say, that's not a great pneumonia story, it's a better heart failure story. It's
like
not
there's something in the stuff that's telling
in their
you.
Story, right? And I mean, I could outline specifics for you, but we'll spare the audience the technical detail, right? But it's, they do that, and then you look at the labs, and the labs don't exactly jive, and you look at the imaging, and the imaging doesn't exactly jive, right? And these things together, and so you say, aha, okay, here's a situation where, now is heart failure a common diagnosis? Yes, right?
Yeah.
But it came in looking a little bit different this time. Is pneumonia a common diagnosis? It also is, right?
Right.
But again, it's not exactly fitting. So my point is that you see kind of, the way we describe it, there's common presentations of common diagnoses.
Right.
That's statistically what you see most of the time. Then there's uncommon presentations of common diagnoses, right?
Right.
And then you get to uncommon diagnoses,
right?
And then you get to the super rare, 1 in a million stuff that usually takes a while to get to because you have to work through all the other stuff first before you even get there. But the point is that medicine is a lot about that process. The practice of medicine is a lot about doing that mental process.
That work,
But the only way you can, to use an AI thing, right? The only way to sort of train yourself, is you have to run through thousands and thousands and thousands of patients, right? To pick up on all these patterns, all the variations, all the things that go on. So in other words, and going back to our discussion from a couple episodes ago, I'd said the thing for me that was the unforgivable sin in medicine was laziness.
Right.
It wasn't lack of knowledge, right? It was laziness. And the reason for that is this, right? The only way to learn the stuff is to beat your head on it over and over and over again. So you have to see patient after patient after patient.
Right.
To just keep training yourself, right? Because it's not like, oh, you finished residency, right? And you've now seen everything there is to see and you know all the cases, right? That's totally not true, right? There's so many more, there's so many variations. And then you see that rare thing that you've only ever read about in a textbook, right? You've never seen it before in your life.
Yeah.
Now you see it because it's the 40,000th patient that you've seen, right?
Right, yeah.
And that's the one where you finally got that, 1 in a million type case that finally walked in your door and you got to see it for the first time.
Right.
So if you don't want to do that, right? If you don't want to do that process of running through those folks,
all the time,
it will be you will gain skill generally speaking, at a slower rate.
Right. So as someone who did that a lot and was really proactive in doing that, it sounds like of getting the bang for your buck in your, your education life. Did you feel prepared when you went to Parsons? Like,
yes.
Was that that was the feeling?
It was, yeah. I mean, there were still tons of things to learn.
It's like, to me, I'm like, man, that seems intimidating to be the one that's up in charge of the hospital, basically, for a town. Where it's like, what if it is one of those crazy cases that comes in that you've never seen before, and not, for anybody, but then it's you and you're new, and you don't know if this is, you just didn't have as much under your belt. Was there cases like that were really stressful in that way of like not having the support above you that you'd had prior?
No, I mean, what I would say, there were two things. So one was that obviously I still had all the context, right? All the physicians that had taught me and trained me, right? So I still had those people. So periodically I would call them up and say, hey, here's a case I'm seeing, right? And it's not going the way I would expect. What can you tell me, right? And very frequently, they didn't need to see the patient again, right?
Yeah.
These are people that were, often 10, 15 years ahead of me.
Right.
Right. That many more thousands of patients, right?
And those lines were, those calls were answered.
Exactly, right? So the line of communication was open, right?
Good.
So then, and this is kind of what I mean, right? So the point was that they could hear the same case that had me a little bit mystified, right? And be like, oh yeah, no, it's this, right?
Yeah.
This is what's going on. Do this, do that, right?
Yeah.
Solves the problem.
That flow chart that's ingrained in them has that pathway a little clearer because they've seen it before.
It's because they've seen so many X thousand more patients, right?
Yeah.
And so that stuff for them is there.
Nice.
So that was one thing that was helpful. Part of it also was just the payoff to all the intensive training and work that had been done before. Yeah. Right, in terms of being able to handle things or do the procedures or whatever, or diagnose things, right, that was there. And then, of course, there still were situations that were, stressful and learning, and it was like the first time I'd ever seen it, and there was no backup of any kind, right? And you have to navigate that. Right. And some of it, I think, also is just the typical sort of, younger, right? You're too dumb to know that you shouldn't be doing this. No, I wouldn't say it was true that you shouldn't be doing it, but it was just. I didn't go in thinking about what are all the things that could go wrong here, right? I went in thinking about this is an opportunity to essentially test the skill that I hope I acquired against a challenging situation, which is being the solo person, right, in a difficult environment.
Personality-wise, do you do well in stressful situations like that, of like rising to a challenge?
I would say so. I like those, especially if I feel it's meaningful. That'd be the There, I would say I wouldn't. I'm not. I think it's, I certainly had experiences of sort of wilting, right, under stress. I think I have had that experience. But I would say that the more worthwhile that I felt that it was, if it came down to, probably the best way to describe it, if it came down to kind of a stamina type situation, so needing to withstand this stress over a prolonged period of time, that I felt went reasonably well. Okay. And this was that kind of environment.
And you've been practicing that for years now.
For all the years, exactly.
Yeah. What were some of the stressful or like just infrastructure breakdowns of being in the rural setting? I mean, that has its own.
It does, yeah. So we would have,
troubles,
we would have situations where, so to give you an example, like if I ordered a radiology study in the urban environment, right, I'd get the read back within an hour or two. Okay. I wouldn't get the read back for 3 days.
Oh, really?
Yeah. So I'd be sitting there saying,
because it has to
so a radiologist has to read the study, right?
So you didn't have a radiologist in house. So
there was. Oh, you
were.
But the reads were just very, very slow, right, and took a long time, right? So here again, right? You said there's all these differences, right, in how healthcare is delivered. So it's a different animal when I can order an X-ray or a CAT scan and expect to get the read back nearly immediately, right?
Right. Because then you might even have the patient still there waiting, right? Sometimes.
Absolutely, right? So what if I order the CAT scans because I'm trying to rule out a certain condition, right? Well, if it takes 3 days for the read to come in, that means I need to keep them on the therapy that I'm trying to remove, right? Because I need to
verify that
I need to verify they don't have this before I can take this therapy away, right? Well, I can't do that until I can actually get the report. Right? Yeah. So if there's lengthy delays in getting the reports on my diagnostics, right? And lengthy delays, incidentally, this is a very common problem in rural healthcare, certainly in Kansas, but probably across the country. Yeah. It's a very common problem, right? You order the diagnostic and it takes a lot longer to get than it takes in an urban environment or a large kind of tertiary hospital environment. Right. And people don't appreciate the difference that makes, right? Yeah. Because again, it results in, prolonged exposure to a medication that maybe you don't need, delayed diagnosis, not making a diagnosis. People just don't order the study because they're like, it's going to take 5 days to come back. Forget it, right? I'm just going to make a guess. I'm going to make my best guess, and we're just going to go on my best guess, right? Yeah. Because I can't get this information that if I was 100 miles over, right, I could get very quickly. That would absolutely change my therapy. Right. Which in this case, it was like if they had another radiologist on staff, would that have been
potentially? And not necessarily.
Yeah, I can't
speak to this hospital specifically, but it sounds like there's lack of time and just there's constraints on maybe even the tools that are available as well in some situations. But that one sounds like maybe just more personnel, like in the back of time.
Some kind of help, right?
Yeah.
And I think if I recall correctly, the doc was trying to do stuff, was trying to do interventions and other things, right, at the same time. So in other words, it's not like the only thing he's doing is sitting there and trying to read films, right? He's also trying to do half a dozen other things at the same time. Again, shortage environment, right? So we've got one person wearing multiple hats at the same time, trying to satisfy all these constituencies, and it's challenging, right?
Yeah.
And again, my point here, and this is, and I want to be careful here. The point here is not, that person's terrible, right? That's not my point. The point here is, here again, you have a system issue, right? You have a system issue, which is what we have is an isolated provider who's trying to do multiple things simultaneously. It's impossible to do all of them simultaneously, right? It's not possible.
Right.
Have we systematically, as a system, I should say, stepped back to say, number one, do we have a problem?
Right.
Well, the answer is yes. Our problem is our diagnostics are delayed, right?
Yeah.
Number two, why do we have this problem? Number three, what solution are we going to propose? The solution of, hey, tie up your sneakers, right, and run a little bit faster is not the solution, right?
Right.
Right.
Yeah.
But that aspect of it, right, if it was going on, at least, I wasn't aware that process was going on. All I had on the front line was, when I order stuff, it may or may not get read, and it may take X number more days than I'm used to, right? This may be going on. So that was an issue. Another issue that was happening in that place was they would have the emergency room so for nighttime admits that would come in. Sometimes they would call me, and sometimes they would have the emergency room doctor write the orders, right? Okay, now you say, well, that's not such a bad thing, right?
And what is pardon this layman's question, but what is writing the orders?
Yeah, so when a person gets admitted to the hospital, right, there's a series of admission orders, right? And it can be however long, but it's basically the hospital, person providing care in the hospital, right, assesses the patient and decides what do I think this is and what do we need to do about it, right? Okay, so the problem is that there's emergency room people who mostly handle outpatient stuff, right? You're walking in with your sore throat or your broken leg or stitches, and they fix that stuff for you, right? And they send you home. Most emergency room people don't do a lot of inpatient time, meaning they don't follow, even if they admit you to the hospital, right? They don't follow you over the X number of days that you need to be in the hospital. They're not doing that aspect of it. Their job is acute, right now, what's happening in this moment for the next couple of hours until I either move you somewhere else or I fix you and you go home, right? Right. Well, in the mind of a lot of hospitals, a doctor is a doctor is a doctor, meaning we have a doctor here and the doctor can do everything. Well, that's not actually true, right? It's not actually true. And I would say you can appreciate a little bit more if I said, well, I've never done brain surgery before, but I'm a doctor. Right? Right? Yeah. So, clearly, I should be able to operate on your brain successfully, right? And you might have a problem with that, right? If I presented it to you that way, right? But this is what we do. So we say, hey, well, you normally work in the emergency room. The emergency room it's almost the hospital in some ways, right? So we can just have the ER just do what the hospital does, right? This is not uncommon, right? This is an approach people take. And it's not that the ER doctor couldn't get it right. It's not that they can't get close. It's that averaged over a bunch of people, right? You're going to have some folks that are pretty good at it and some folks that aren't very good at it because it's really not what they do, right? And they haven't done it for years. It's been a long time since they were anywhere near a residency program to do this, right? They didn't have any of this. But you're asking them to put on a very different hat. And why are you asking them to do this? Again, shortage situation, right? So you're saying, hey, we've got this one doctor out here. This is all we can afford to have out here, right? Yeah. We don't have any other night coverage, so we're going to have the ER doctor put in the orders, right? So one of the ER doctors, for example, there was an older lady that came in with a low sodium, right? So he put her on an IV fluid at a very high rate that made her sodium drop even more, right? So when I walk in the morning, she's having a seizure, right? Right? And I'm like, she survived, okay? She survived, okay? But when I went in and looked at this, I was like, this was completely predictable and preventable, right? This never needed to happen. This lady didn't need to have a seizure. Yeah. What happened was the person writing the orders, whatever happened, right? Right. This was the wrong person to be doing this. Yeah. And it caused a harm.
Wrong call.
Right? It was the wrong call and it caused a harm. Yeah. But why is this happening, right? Yeah. Well, it's happening because we don't have enough staff here. Right. So we're just making do, right, with whoever and whatever we can put together.
This might be a bigger question for later on, but what you just said, like, we don't have enough here. Yeah. Is that a money issue?
Yes.
Is that it?
It's a money. Well,
Or
one
supply.
is so
Doctors
one is
who are
geographic
willing,
isolation,
like,
right? You're in
yeah.
a town where it's not that many people are going to want to come there.
Yeah.
Right? It's a small town.
Okay.
It's in a rural area. It's not a lot of
So the supply
amenities.
of medical help is possibly small.
The list of people that want to come
Yeah.
is relatively, and on a permanent basis, right? Is
Right.
relatively short. There are people that will come out on a so-called locum tenens
travel.
basis, right? But you're going to pay a ton of money per hour, and that's prohibitive. You can't do
Right.
that forever because
Yeah.
it's very expensive.
Yeah.
So you can get who you get, but when you're talking about sort of a stable long-term situation, the list of candidates is usually short.
Yeah.
So you can't get them that way, right? And then on top of that, even the ones that you get, right? In some cases, that you don't have the pick of, there's 300 applicants for this job, right?
Right.
You have 2, right?
Right,
Or 1,
right. So you're like either yes or no.
Either yes or no,
Yeah.
right? And it kind of doesn't
And you know
matter
that you need
necessarily.
somebody.
If you got to have a person there, you got to have a person there, right? And so whether they have all the experience you would want or whether it's optimal, you know what I mean? You can't be that picky in an environment of shortage. And so this is really a system problem, right? And so the issue later on, right? One of the motivations to start the virtual care, right, in rural was a realization that, okay, what did we need to not have that lady have a seizure?
Right.
What we needed was somebody that was available that knew the right thing to do.
Right.
That's what we
Not
needed,
an
right?
ER doc, but someone who was more...
Or not that ER doctor, whatever it was,
Yeah,
right?
yeah, but,
Specialty aside, like, we needed someone in the proper position who was available at that time to make a better decision for that patient, right? That is what we needed, and we didn't have it. And we didn't have it because in that context at that time, the only way to get a doctor there was to physically transport a physician to the place. But in reality, that's not true, right? The correct decision could have been made with just the data. If you just had the lady's story and her labs and whatever else, you could have known, and that's probably a poor choice, right? We should either not do that.
Without ever actually
without even being there,
her,
right?
Yeah.
But this is just like a mind-blowing concept to many people in healthcare and certainly to many hospitals, right?
Yeah.
What you need is the right mind in the right place, not necessarily the body.
Right.
Right?
Yeah.
It's not necessarily the body. But many hospitals have opted for, I want the body.
Right.
Right? If I have the person here in front of me, that's clearly the right thing to do, but it's not. Because if they don't have the right knowledge, their body being there doesn't actually help your patient anyway, but it makes you feel better because you have filled a staffing spot, right? So there again, we had a system problem, right, that was going on where the care was worse than it should be because of that. I'll use even myself as an example, right? So I'm here as a brand new graduate, right?
Yeah.
And the problem that happens a lot of times is when you go out into a smaller environment, right? In some cases, you may be the most knowledgeable person in your little tiny environment, right?
Right.
That doesn't mean you know everything. Right?
Definitely.
It just means you're the most knowledgeable person in this environment, right? You may be a small fish in an even smaller pond, right?
Right.
Right? And this is the problem, right? And so, just to give you an example, like when I think back to some of the decisions that I made then, right?
Yeah.
And I'm like, you know what? Yeah, I should, now knowing what I know now, I would have done something different in that situation, right?
Right.
It wasn't necessarily that somebody was hurt by it or whatever the case is, but it's like, I could have probably gotten to the end of that case faster.
Right.
Right?
Well, like you've mentioned on House, the show, how ridiculous it is. When we were chatting earlier last week, I think you mentioned like he would have needed to have 20 fellowships and all these different things to know the amount of knowledge that he knows.
Yes.
And it's like, that's a great example for lay people, I feel like, where it's like, we're given this thought of like, oh, our doctor knows all of this.
Right.
And then we see something very different in the room.
Yes.
Often because it's a very short amount of time that we're with the doctor anyway. So we really don't even know what they know.
Yes.
So there's this dichotomy of like expecting House
Yes.
and then getting an ER doc who's treating you in a different way or something. And then that being a frustrating thing where you're like, well, you're supposed to know this much. And it's like, really, it's somewhere in the middle is true for someone coming out of residency and becoming, an attending physician. It's like, we shouldn't expect a doctor in that realm to have that much knowledge, right? But I think what you said before of the laziness piece, like that's the big piece that I see. I'm from a small town also, and so that I've had really good instances with some of our doctors who followed us through all of our, until I moved out of that town, my parents still see these people, but it's like, because they were the ones that, similar to you, have dug in and been really curious about things more than either feeling like they know everything themselves. And like, it's like I feel like as a patient, I've been so interested in a doctor whenever they've shown interest in me where they're like, I don't know, I'm going to do some research on this. I'm like, okay, I respect that answer. Like, because if you knew everything at the start, then, why couldn't I just call you?
Yes.
And I mean, the answer to that sometimes is you can though, right? And so that's where, can you talk a little bit about the rural, just briefly, because we haven't really talked before about Free State very much.
Yeah.
And so can you give a brief synopsis for our listeners of what the rural side of the Free State piece is?
Yeah, I mean, originally the formulation of Free State was to try to address some of these issues, right? So it was to say, let's use virtual technology to provide more reliable and potentially greater expertise in terms of more reliable coverage and potentially greater expertise to small towns that otherwise would not have easy access to it.
Yeah.
That was the basic concept.
And this was before other telemedicine opportunities had really risen, right?
This started in 2014.
Yeah.
So it was before there was a hot topic or anything like that. And the point was also to reduce the cost of care. So to give you an example, a lot of rural facilities, they might be paying $200-300 more dollars an hour, right, to have somebody come out, but they didn't in person, right, to have someone come out in person, but they didn't have the patient volume, right. And then on top of that, they had the restriction of they could only get someone that wants to come there, who's also actually available at that time,
right,
and is able to do the travel, right.
Yeah.
So the list of candidates is actually fairly small.
Right.
Right. And then you didn't necessarily have control over the quality at all of what went on. And there were people who's actually coming to you, right? This was the problem.
Yeah.
So you're paying a ton of money in a way that at a price that's unsustainable for you long term as a facility. You don't have the patient volume for it. You have no control over the true quality or expertise of the person that's coming in.
Yeah.
Right? Especially if they're coming in on kind of a random one-off basis, right? They come and do a week a year or something. You know what I mean? You can't see them on enough.
Is that pretty common in rural areas to have
absolutely.
Visiting docs that
very,
are
very
just
common.
Super short term like that?
And here again, to kind of take it back to my experience then, so one thing that happened, I'll never forget this, I had a guy come in to do a coverage for me on a weekend, right?
Yeah.
Over that weekend, he killed 2 of my patients. Straight up, yeah. He came in, mismanaged them, I came back, and they were dead, right? One of the guys, one of the guys, I came in to get sign out from him. Yeah. On Sunday night, and he said, "Oh yeah, this gentleman's been here. He's real sleepy. He's real sleepy. Yeah, we haven't been able to wake him up. And I'm like, oh, okay, he's real sleepy. Like, how long has he been asleep? Oh, since Friday. He really hasn't. I said, I'm sorry. What?
What?
The guy's been asleep since Friday. Like, what have you done? Oh no, he's just real sleepy. We just say I think he has a urinary tract infection. I think that's what's going on. But
he was an admitted patient to the hospital.
An admitted patient, yeah. And I'm like, you think he has a urinary tract infection, but he's been unresponsive since Friday. It's now Sunday night.
Oh my goodness.
And you haven't done anything with him? Anything at all? Nothing, right? The guy died, right? The guy died. He had a massive stroke.
Oh my gosh.
Completely missed. Nothing was. He didn't have a urinary tract infection instantly, and the data was very clear. Actually, when you looked at the lab, it was very clear. He never had that in the first place, right? This was a locums who they'd brought in, right, to provide me with respite for a weekend, right? So this is my point, right? So I'm here as the main guy working all around the clock and getting called, right? So every now and then they try to give you a break by bringing somebody in, right? So they brought in this person, and this is what he did. And I forget what the other case was, but it was very similar, where it was just, from a medical perspective, what the decision making was just indefensible. It was just absolutely indefensible, right?
And these are regularly practicing doctors from elsewhere that are leaving their practice.
That person was a fellow in a special subspecialty training program, right, from the Midwest region. Yeah.
Okay.
Yeah, he was a fellow at that time. This is what went on, right? And so I was like, wow, okay, this is just terrible. Like,
any repercussions for this, like for that doc of like.
Well, what the repercussion was, I talked to the hospital and said, we can't ever have this guy back, right? We can't ever come back.
Does that follow him, though, to other...
No, it doesn't. No.
Man.
It doesn't. It goes to the company that brought him in. If they choose to ignore it or not to do anything with it, if they choose to book him for future assignments. Yeah. I have no idea what they chose to do. Yeah. But if they choose to do that, and there is a strong financial incentive to choose to do that, that's a whole discussion of the Loc Tenant Industry, which is different. Strong financial incentive to choose to do that. there will be, unless you file a formal complaint, like you put file something on their license or whatever the case is, this stuff just goes nowhere. That's the end.
Which would that have to be like families pursuing a lawsuit?
So there could be families that would pursue a
something?
lawsuit, or it could be the facility, or somebody could file a report with the state, right, to try to say, hey, here's we have a complaint against this. That's a lengthy and often complex process, right? And so a lot of times stuff like this just kind of goes on. It just kind of goes on, and that's if it's even detected, right? Which is a whole nother issue. Sometimes it's not detected. Right, in the first place, nobody even realizes what went on.
Because it's just like, oh yeah, this patient had a urinary tract infection, then went to sleep, and then died.
It's
that's the story that gets written down.
That's the story that goes on, right? And it was just terrible, and who knows what happened, right? But it was just it's probably their time to go, and so it was just their time. That was the end, right? So there again, it's an example of you have a system problem, right?
Yeah.
You have a shortage of people. You brought in who you brought in. They're not doing a great job. You have a forward-facing system problem, which you described, which is this person doesn't seem to do a good job of managing in this situation.
Right.
Is there any monitoring of that? Does anybody know about it? Is there any feedback given? Is there any additional education? Has anybody investigated any other work?
Because I'm thinking about like Catholic Church, the priests that have done egregious acts have then continued to be shuffled to other places. And I'm like, you're talking about traveling doctors who are hired for a week at a time. Very easy to not have oversight.
There is an element of that in medicine with absolute certainty. Yes, there is. There's an element of people know. Yeah. But
it's too hard to jump through all the hoops to have anything happen.
So there's several different things. One is it's hard to jump through the hoops. Two, it becomes very political very quickly, right? Yeah. You start burning the house down, right? Then that can get really ugly really fast, right? Now you're getting dragged into stuff, and it's very and the fraternity of physicians is relatively small, right? In any given community, everybody kind of knows everybody, or there's some relationships. You see what I'm saying, right? Yeah. It's very similar. So it's like, well, that was done wrong, but there's probably some extenuating circumstance. Oh, it's not that bad. A lot of that goes on. And part of the reason a lot of that goes on is some of it is the politics and stuff I've described. Some of it is also the longer you practice, you develop some mercy because you also make mistakes, right?
Of course.
You try not to hopefully not make mistakes that ridiculous and that egregious, right? But you make mistakes, right? And as you do that, you start to say, well, okay,
there's mistakes, but then there's gross negligence.
Yes, there's a difference, right? Yeah. And I would describe that really as gross negligence, right? But what I just described as gross negligence, right? But you make mistakes, and as you do that, I think it's true for human life in general, right? You go through your life and you mess things up, and you become more merciful, right? As time goes on, as you get older, and that's true. The problem is you don't have a way to know. Is this a pattern of behavior? Right. Or is this just somebody had a really bad day, right? You have no way, because I don't know this person that's come in.
And you're not even there, at the same time that they're there.
This is the issue, right? So I don't know what went on that I didn't even know about, right? The patient came in and left before I got here. I don't know about any of that. I don't know about any of their past practice habits. Right? So I don't have any baseline to know them. And so it makes it very hard to say, well, is this, again, a one-off situation? Or is this somebody that really shouldn't be doing this? Right?
And is this happening in multiple places that they're traveling this year?
No, and the answer is nobody, to my knowledge, knows that information. It is knowable information, but nobody knows that information in actual reality. This is one of the problems, right, that goes on. And even, I will say, even when we do know it, even then, that's when you get into the politics and all the other stuff that goes on where
being
people
able to do something about
get around, nothing really exactly happens, and they just sort of keep going. That also goes on. And it tends to go on most often in smaller environments, again, where there's fewer eyes, right, watching things and fewer people that know, but it goes on all over. It's not like the small places are the only ones that have that problem.
That's interesting. We're about out of time, but I want to ask, because I know that from there you went to Seattle, right?
I did, right? But I should add, before we jump to that, if we have the time, one other system story that happened in this. So there was also a patient, he's a young man who came in for a tonsillectomy. Okay. It went very badly. He starts bleeding out, and he died, right? He died from this. But as part of this process, before he died, they were trying to get an airway on him, and everything was just filled with blood, and it took a very, very long time. So he took an oxic injury to his brain, right? So this is a tragedy, right? I mean, this is
what does oxic injury?
I'm sorry.
Mean?
So he didn't get enough oxygen supply to his brain for too long, right? Yeah. So in this situation, at that point in time, right, at that point in time, there was some question about, could you cool the body down, right?
Yeah.
To try to stave off some of the worst of the injury,
Right.
And the evidence on it wasn't great even then, right? We kind of knew it wasn't great. But
Yeah.
so here I am, I'm in this small hospital, right?
Yeah.
Isolated from everybody. And I'm like, I've got a 30-year-old here who is dead now, right? Due to a surgery gone wrong.
Yeah.
I need to send him somewhere bigger than here, right?
Yeah.
Because I was like, if he's going to have any chance, right, of survival, he's got to be somewhere other than here with me in a place with limited resources, right? And I called all over the place, and I got turned down for
medevac kind of situation.
Yeah, no, I tried to call other hospitals and say, like, will you please take this guy?
Yeah.
Right? The runaround, I spent hours and hours and hours getting run around on the phone. Well, we don't know. I mean, the evidence on, hypothermia in this situation is really not good. So I don't know that we'd really have anything to offer him, right? And I'm like, he's 30 and he's going to die, right? And I don't have anything here to address this with. Yeah, but I don't know that we could help him in our massive, quaternary referral center. We couldn't help him. Well, we might take him, but I need to have my subspecialty service really on this also. And they need to agree to take him first before I would take him, because if they're not going to agree to do this, so you need to call them and then get them to approve. And then if they approve, then you can call me back and then we can have another discussion about this, right? And meanwhile, right, this guy has taken a brain injury and the clock, I'm just watching the clock tick, ticking. Right? And I'm trying to call around and I either can't reach people, they don't call me back. When they call me back, they give me a runaround, they give me a denial that's just based on, they really just don't want him coming there to die. That's the real answer, right? And there's no thought in any process of this that this is a person who has just had a tragic event happen to them as a result of exposure to the healthcare system. Right.
A routine
procedure
surgery,
that usually goes well, right? Yeah. It didn't go well in this case, right?
Yeah.
But there's no coordination. There was no way for me to know who had beds available. Everything was done in a manual process. Right? I had to sit there and say, okay, I'm going to call this place, then I'm going to call that place, then this one, 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 right? And then I'm going to get a wide variety of responses.
Yeah.
Right? And so I spent 3+ hours, right, just begging to try to get this patient transferred to somewhere that could do anything for him, more than what I could do, right? Here again.
And they're like, hearing you say that, in my mind, I'm like, I'm shocked that there's not a place that is like your go-to place of this is a bigger hospital than this. Oh, they're a big brother, and we always send patients here.
You can try, but they may not have beds, or
it's not like our regular.
They may not accept. They just may not accept. Yeah, this is very common, right? So they'll come up with a reason not to accept. Right, this is extremely common to see. Right, there'll be a reason not to accept, and so you in the small hospital, right on the rural side, are stuck with a patient that you can't help.
Wow.
But no one will take them for any number of reasons on their side.
But I'm assuming that the main one's not lack of beds, or
at that time it was. Now it is. These days it is.
Right.
Back then it was not lack of beds. They had plenty of beds. They had plenty of staff. They had plenty of beds. Right. It'd be various other reasons that they would come up with to not take the patient.
Is there some sort of financial penalty or advantage to not having people die in your hospital?
Yes.
Is it a statistic
So if your death rate is too high, right, that's bad.
So they're that. Hesitant maybe on some of these. Yes.
If you're going to take one that's probably going to die, right, that may or may not affect your statistics.
Isn't that against a doctor's oath?
Yes, it is. Yes, it is. But it's a statistic to which payment is tied, right? So this is a consideration that goes on. What insurance the patient has is a huge consideration, right? You get that question almost all the time.
They know that ahead of time.
Oh yeah. No, there are places they don't want to talk to you unless the patient has the right. So they'll do a financial analysis before they will accept the transfer. It's not a question of what can we do for them medically.
Wow.
It's how would this be paid for by anybody, right? And if it can't be paid for, then don't call us, right? We don't care if we have a bed or not. Like, we're not going to be able to accept that patient. And the answer is because they don't have the right insurance. Right,
and if the patient was to walk into their ER, they'd have to.
They'd be obligated by law.
To come from another hospital,
That's correct.
They have to receive them.
That is correct. They have to receive them. And I mean, so reasons can be as bad as that. Yeah. Sometimes it's also just, the doc on the other side is just having a bad day. They're just overloaded and busy, right? I mean, these are real things, right? These are humans on the other side. Yeah. They're tired and they're like, you know what? I don't want to deal with this. This is going to be a train wreck of a case. It's going to be very difficult. I'm on my 10th admission for the day, right? I have too much already going on here. I just don't want to deal with it, right? So I'm going to come up with an excuse to punt this case, right? And you say, again, from the perspective of an outsider, you say, well, that's ridiculous, right? That this shouldn't be the case. You know,
Right.
why would you're jeopardizing the life of my family member, right? Because you're
Right.
tired, right? You know,
Right.
and that's not wrong, right? That's not a wrong emotion. The problem is the opposite side of it is also true.
Right.
They're on their 10th straight admission. They're getting beaten into the ground.
Right.
They don't have adequate support on their side. They're usually
Right.
dealing with an electronic medical record that makes their life even more miserable, right? So,
But
how
really
do you reconcile?
frustrating to have that whole situation.
Right.
I mean, on either end, like
This is the problem, right?
Yeah.
So these aren't individual problems, right? It's
Right.
not like, oh, that was a bad doctor on
Right.
that receiving
You did
facility
bad.
side, right?
Right,
Or it was
yeah.
a bad doctor on this side.
yeah,
These are system issues where there's a total lack. To give you an example, there's a lack of collaboration. So, for
Right.
example, we should know which beds are available where
Right.
at least across the state.
Yeah.
At least across the state.
Yeah.
Every hospital that has an open bed should be in a database somewhere that we can just go
Right.
to and be like, St. So-and-so's, they got a bed, they got an ICU bed that's open right now, right? I can
Right.
apply for that to get my patient in. That type of information should be shared. It is not shared, right? What resources this place has versus that place has should be open information. It is not shared, right?
Really?
So you call them and you don't know necessarily. You assume they have X
Yeah.
specialty or Y diagnostic machine. You don't actually know that.
Yeah.
So instead you have to go through the process of calling them to find somebody,
out.
right? Or more often these days,
and
you
like
go through
it's
to
you,
find-
it's
Yeah.
you calling,
Right.
which is
You-
amazing
yes.
to me. Like to hear that, where I'm just like, wow. So
Yes.
my doctor, when
Yep.
I'm not, like
Right.
when I'm waiting for that crucial
Yes,
move,
that's
it's like
correct.
he's in the other room
Yes.
doing this.
Yeah,
like,
in small environments, that's absolutely the
Yeah.
case, right? Even in bigger, still it's somebody, some member of the
Yeah,
healthcare
some-
team, right,
some
is
pieces.
making the call
Yeah.
to try to do this or calling around to try, and then you still have to do your, you have to do your doc-to-doc checkout, right?
Right.
Describe those things. I mean, all of this is happening, and you look at it and say, this is all chaos, right? And it's
Yeah.
chaos because, these hospitals all have different ownership,
Right.
They have different electronic medical records. They have different staff
Right.
that often have no connection to each other whatsoever,
Right.
and there is no attempt to collaborate anywhere, unless they're all in the same system with the same ownership. There is
Right.
no attempt to collaborate between any of them ever. And COVID, which we saw many years
Yeah.
later, just put a huge spotlight
Right,
on
on
what a
that.
disaster it is when you have 15 different actors, none of whom know what the other is doing.
Right.
In many cases, right, and are not collaborating in any obvious ways
Yeah.
to decide how to use the resources that we have efficiently.
Right. Well, I mean, in one way, not that it was positive in many ways, but in the public's knowledge, at least, like during COVID, it was an interesting part because we were getting regular news updates of
Yes.
our hospitals of how many beds, what percentage
Right.
were full and what were empty. And I was thinking that when I was reading these stats where I'm like, I don't know how this compares
Yep.
to normal
Yep.
because we've never been given this information before.
Yeah.
And so I think that's, like you said, it's trying to spotlight, I think, for the public as well, in a way that was like, it started to make me question those things of like, well, I can see the stats now, but
Yes.
I don't know what this is compared to, except last week, COVID stats, and then the week before COVID stats. But like prior to COVID, like what were the stats?
Yeah.
Because I have no idea. And I didn't need to know necessarily before, but it is an interesting piece where it's like, we have such transparency of information in a lot of realms of our lives.
Right.
And you would think that at least between institutions that there would be some sort of piece to that, but no, not at all.
Usually there is
Sounds
not.
like.
Usually there's
Interesting.
not. Yep.
All right. Well, that is our time. Next time we'll be talking about your trip to Seattle and what that was like. You've told me that you were at a referral center. Is that right?
Yeah.
Yeah. I don't know what that is, so we're about to find out. Awesome. Thanks, Elisha. Thank you, guys.